The physician performs an endoscopic retrograde cholangiopancreatography, ERCP, for diagnostic or therapeutic reasons, depending on the code. The physician passes the endoscope through the patient's oropharynx, esophagus, stomach, and into the small intestine. The ampulla of Fata is cannulated and filled with contrast. The common bile duct and the whole biliary tract including the gallbladder are visualized. ERCP, diagnostic, including collection of specimen, S, by brushing or washing, when performed. With biopsy, single or multiple. With sphincterotomy/papillotomy. With pressure measurement of sphincter of Oddi. With removal of calculi/debris from biliary pancreatic duct, S. With destruction of calculi, any method, e.g., mechanical, electrohydraulic, lithotripsy. ERCP, with placement of endoscopic stent into biliary or pancreatic duct, including pre- and post-dilation and guide wire passage, when performed, including sphincterotomy, when performed, each stent. ERCP, with removal of foreign body, S, or stent, S, from biliary/pancreatic duct, S. ERCP, with removal and exchange of stent, S, biliary or pancreatic duct, including pre- and post-dilation and guide wire passage, when performed, including sphincterotomy, when performed, each stent exchanged. ERCP, with transendoscopic balloon dilation of biliary/pancreatic duct, S, or of ampulla, sphincteroplasty, including sphincterotomy, when performed, each duct. ERCP, with ablation of tumor, S, polyp, S, or other lesion, S, including pre- and post-dilation and guide wire passage, when performed. Endoscopic cannulation of papilla with direct visualization of pancreatic/common bile duct, S. Laparoscopy, surgical, esophagomyotomy, Heller type, with fundoplasty, when performed. Laparoscopy, surgical, esophagogastric fundoplasty, e.g., Nissen, toupee procedures. Laparoscopy, surgical, esophageal lengthening procedure, e.g., Collins gastroplasty or wedge gastroplasty. Laparoscopy, surgical, repair of paraesophageal hernia, includes fundoplasty, when performed, without implantation of mesh. With implantation of mesh. Esophagectomy, total or near total, with laparoscopic mobilization of the abdominal and mediastinal esophagus and proximal gastrectomy, with laparoscopic pyloric drainage procedure, if performed, with open cervical pharyngogastrostomy or esophagogastrostomy, i.e., laparoscopic transhiatal esophagectomy. Esophagectomy, distal 2/3, with laparoscopic mobilization of the abdominal and lower mediastinal esophagus and proximal gastrectomy, with laparoscopic pyloric drainage procedure if performed, with separate thoracoscopic mobilization of the middle and upper mediastinal esophagus and thoracic esophagogastrostomy, i.e., laparoscopic thoracoscopic esophagectomy, Ivor Lewis esophagectomy. Esophagectomy, total or near total, with thoracoscopic mobilization of the upper, middle, and lower mediastinal esophagus, with separate laparoscopic proximal gastrectomy, with laparoscopic pyloric drainage procedure if performed, with open cervical pharyngogastrostomy or esophagogastrostomy, i.e., thoracoscopic, laparoscopic and cervical incision esophagectomy, McKeown esophagectomy, triincisional esophagectomy. Unlisted laparoscopy procedure, esophagus. The physician performs an esophagogastric fundoplasty using a laparoscope. With the patient under anesthesia, the physician places a trocar at the umbilicus into the abdomen and insufflates the abdominal cavity. The physician places a laparoscope through the umbilical incision and additional trocars are placed into the peritoneal or space. Additional instruments are introduced through the trocars. The physician identifies the fundus and the esophagus and resects them. The fundus is wrapped around the lower end of the esophagus, which is rejoined to the stomach with sutures. The trocars are removed and the incisions are closed with sutures.